1, 2,
And
Patients here.
70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Usually, when you think about a medical diagnosis, you kind of expect a certain level of mechanical precision.
Right, yeah.
You know, you break your arm, the x-ray shows a jagged white line on a black background, and the doctor just points to it. You're like, here it is.
It's visible. I mean, we inherently trust things we can categorize and, fix with a physical intervention.
Yeah, exactly. But the second you step into the world of mental health, psychiatric care, and psychosocial development, that x-ray machine is just useless.
Completely useless.
You're suddenly operating in a diagnostic landscape that is incredibly murky. And so to set the stage for anyone listening right now, especially if you're, a nursing student or a practitioner prepping for boards or just someone who is obsessed with how the human mind works, I want to throw a pretty profound clinical mystery at you.
Ooh, okay. It really is like the ultimate puzzle of human development.
It is.
Yeah.
So imagine two people. They are born in the same town, raised in the exact same stressful, neglectful, just heavily abusive environment.
Okay, so same baseline.
Right. They share the same socioeconomic background, the same chaotic starting line. Now, fast forward 30 years. One of them has grown up to build a deeply fulfilling life. They have a healthy marriage. They're successful in their career. They are, engaged in their community.
Wow, okay.
But the other person, they are struggling to survive. They are dealing with profound isolation, severe treatment-resistant depression, and a debilitating alcohol use disorder.
Yeah.
Same starting line, completely different destinations. Why?
See, that why is the foundation of everything a safe, effective practitioner does. I mean, if you want to master clinical judgment, if you want to actually safely care for patients and, pass those high-stakes NCLEX or board exams, you can never just memorize a list of diseases.
Right.
Like memorizing the DSM-5 criteria for depression, it won't tell you why those two individuals ended up on completely different paths. You have to understand the biopsychosocial human beings sitting on the exam table.
Okay, let's unpack this, because that is our mission for this deep dive. We are throwing out the one-size-fits-all textbook approach.
Good. Because it doesn't work.
We want to decode the individual, the interpersonal, and the cultural factors that dictate whether a patient survives their environment or thrives in spite of it.
Yeah, think of this as your highest yield clinical roadmap. As an educator, I am always looking for the 20% of knowledge that gives you 80% of your clinical understanding.
80-20 rule.
Exactly. Treating a patient isn't about handing them a pill and checking a box. It's about understanding the specific biological engine they are running on, the psychological armor they've managed to build, and the cultural lens through which they view health and illness. We need a framework to provide culturally humble, holistic care that actually works.
We have to start at the literal foundation then. Before we can even look at a patient's culture or their home environment, we have to look at what they're physically bringing to the table the day they are born, how they develop from there.
Right, because a person's age and developmental stage, they fundamentally dictate how an illness will express itself. It completely changes the prognosis.
So it's not just about the disease, it's about when it hits.
Yes. Let's look at a highly testable clinical scenario, schizophrenia.
Oh, this stood out to me as a massive paradox in the material. Usually in medicine, youth is an advantage.
Right, you bounce back.
Yeah. If you get sick when you're young, you recover faster. But with schizophrenia, a younger age of onset predicts a much poorer outcome. Like a 19-year-old who experiences their first psychotic break is statistically facing a much harder, more debilitating road than a 35-year-old having their first episode.
That's right.
I just don't understand the mechanism there. Why wouldn't the younger brain be more adaptable?
Well, it comes down to what the individual has had time to structurally build in their life before the illness hit.
Oh, interesting.
Yeah, so a person who develops schizophrenia in their mid-30s, they have already lived through crucial psychosocial milestones. They have likely experienced successful independent living. They know how to pay rent, hold down a job, navigate social relationships.
They have baseline of functioning.
Exactly. And most importantly, they have a well-developed sense of personal identity. They know who they are outside of the illness.
It's like trying to navigate a massive Category 5 hurricane in a ship that hasn't even finished being built yet.
That's a great way to put it.
Like, if you are 19, you're still in the shipyard. The planks aren't nailed down, the sails aren't rigged, you haven't even finalized the blueprints of who you are.
Yes.
Contrast that with a ship that has already sailed across a few oceans. The older patient has the structural integrity, the life skills, to weather the storm of a psychotic break.
That structural integrity is everything. That lack of it in the younger patient is exactly why you see a higher prevalence of negative symptoms.
Like apathy.
Apathy, severe social isolation, a complete lack of volition. They literally do not have the coping mechanisms to fall back on.
Wow.
And this applies across the board, not just in severe psychiatric disorders. Think about a 7-year-old child with severe anxiety or ADHD. They completely lack the vocabulary to describe their internal state. They can't sit in a chair and say, I am feeling overstimulated and unable to focus due to executive dysfunction.
No, they just throw a chair across the room.
Exactly. The nurse has to be acutely aware of the developmental stage and translate that behavior into clinical data.
Which brings us to the roadmap for those stages. Erikson's psychosocial stages. If I remember my psychology classes, this is like the gold standard for understanding where a patient is developmentally.
It is a massive, high-yield concept for exams and clinical practice. Erikson's model spans from birth to death, and the core rule is that development isn't guaranteed.
Wait, it's not?
No. Each stage depends on the successful completion of the previous one. You face a crisis, and you have to pass the test to level up.
Okay, let's look at the very first one, because it seems to set the tone for the rest of a person's life.
Yeah.
The infancy stage. Birth to 18 months. Erikson calls this trust versus mistrust. The task is that the infant must learn to trust that their caregivers will meet their basic needs. Feeding, changing, comfort.
Now, apply clinical judgment to that. What happens when an infant fails that stage? What if they are neglected or the environment is chaotic and unsafe?
They develop mistrust.
Right, but it's deeper than that. They don't just have a difficult childhood. They physically and psychologically fail to develop the hardware required to form trusting relationships.
Oh, wow.
If you don't build the foundation of trust at 18 months, you cannot suddenly manufacture it when you are 25. You get developmentally stuck.
But wait, how does that actually manifest in a clinical setting? Like if I'm a nurse admitting a 30-year-old patient to a psychiatric unit and they got stuck at trust versus mistrust, what does that look like in the room?
It looks like extreme paranoia. It looks like a patient who refuses to take their medication because they are convinced you are trying to poison them.
Oh, so they're not just being difficult.
Not at all. It looks like someone who cannot form a therapeutic alliance with their care team, no matter how empathetic the nurse is, because their foundational worldview is that humans are unreliable and dangerous.
That is heartbreaking.
It is.
Yeah.
And you can't just educate your way out of that. You have to understand you are dealing with an infant's unmet need wrapped in an adult's body.
Okay, that makes sense for childhood trauma. But what about adult development? We tend to talk about developmental stages as if they end at age 18.
Like you're done growing.
Yeah, like you get your high school diploma and suddenly you're fully baked.
That is a dangerous misconception in healthcare. Adults have rigorous, highly specific developmental tasks.
Okay.
The framework breaks adult growth into 3 distinct stages. First, the young adult, roughly ages 25 to 45.
So what's their crisis?
Their primary developmental tasks are about forming intimate bonds with another person, establishing financial and residential independence from their family of origin, and building a career. Erikson called this intimacy versus isolation.
Building a separate life, basically.
Yes. Then the middle adult, 45 to 65. The tasks shift dramatically.
How so?
It's no longer just about establishing yourself. It's about maintaining healthy life patterns, launching children into the world, and often reversing roles to care for aging parents.
Oh, the sandwich generation.
Exactly. It's a phase of generativity, achieving mature civic and social responsibility.
And finally, the older adult, 65 and older. I imagine this is less about building and more about, reflecting.
Heavily focused on adjustment. Preparing for retirement, adjusting to inevitable physical decline, finding meaning in life after you no longer have that career that defined you for 40 years.
And adjusting to the death of friends or a spouse.
Right. Erikson called this ego integrity versus despair.
Let's talk about the failure of that specific stage. Say you have an older adult who retires from a career they loved, and they just can't find meaning afterward. They fail that developmental task.
Well, that failure leads directly to despair, isolation, and a profound lack of confidence. And clinically, this is vital.
Because it affects their health outcomes.
Massively. A patient experiencing despair because they feel their life lacked meaning will have significantly less motivation to adhere to a treatment plan.
Oh, that makes total sense.
If you diagnose them with diabetes or heart disease, they might not bother checking their blood sugar or changing their diet. Why would they? They have no ego integrity keeping them anchored to life.
Wow.
Compare that to a patient who has successfully navigated that stage. They will fight tooth and nail through a tough diagnosis because they still find value in their daily existence.
So the nursing assessment isn't just taking vital signs, it's assessing where they are on Erikson's timeline.
Absolutely.
But we can't ignore the physical vital signs or the literal biology. Let's pivot to genetics, specifically pharmacogenetics, because this feels like an area where nursing judgment is literally life or death.
Oh, it is. We know genetics play a role in psychiatric disorders. Bipolar disorder, major depression, substance use disorders, they all have strong familial links. But pharmacogenetics is where biology meets daily medication administration. It is the study of how an individual's specific genome influences their response to drugs.
Okay.
We categorize people into poor metabolizers, intermediate metabolizers, and ultra-rapid metabolizers.
And I need to visualize this. Let's say the medication is water flowing from a faucet, and the patient's liver enzymes are the drain in the sink.
Okay.
And the faucet is the daily prescribed dose.
I like this. Keep going.
If a patient is a poor metabolizer, that means their drain is essentially clogged. It's working at a fraction of the normal speed.
Right.
So if the doctor prescribes the standard daily dose, like the faucet is running at a normal speed, but the drain is slow, the sink is going to overflow.
Yes, exactly.
The drug stays in their bloodstream, their serum, at a much higher concentration for a much longer time.
And an overflowing sink in this scenario means severe, potentially life-threatening drug toxicity.
That's terrifying.
A standard therapeutic dose for an intermediate metabolizer could be a lethal dose for a poor metabolizer.
Hold on. If someone is a poor metabolizer, doesn't that mean we just shouldn't give them that class of drug at all?
Not necessarily. It means the provider might need to prescribe a microdose compared to the standard guideline and monitor them incredibly closely.
Okay, that makes sense.
But look at the reverse scenario, the ultra-rapid metabolizer.
So their drain is wide open, the water pours in, and immediately flushes out before it can even fill the basin.
Exactly. They process the drug so fast that they get zero therapeutic effect from a standard dose.
Oh, wow.
And here is where the nurse's clinical judgment is critical. If you have an ultra-rapid metabolizer on an inpatient psych unit, they are going to look non-compliant.
Because they're not getting better.
Right. The doctor might think they are chicking their pills and spitting them out, or that they have a treatment-resistant form of depression, when in reality, their liver is just burning through the SSRI too quickly.
The nurse isn't the one running the genetic sequencing in the lab, though. So what is the frontline responsibility here?
Well, you are the one evaluating the efficacy of the medication hour by hour.
You're at the bedside.
Yes. If you administer a standard dose of an antipsychotic and the patient is showing signs of severe extrapyramidal symptoms or toxicity just a few days later, your clinical judgment should trigger the thought, could this patient be a poor metabolizer?
Right.
You don't just blindly follow the medication administration record and give the next dose because it's scheduled. You advocate for the patient, you hold the dose, you assess for safety red flags, and you contact the provider. That is the essence of clinical judgment.
So we've established the biological hardware, age, developmental stages, genetics. But hardware needs software to run. How does the mind actually protect against the stress of illness?
We transition to the psychological tools a person can actively build. And this is where nursing interventions can be incredibly empowering.
Okay.
And it starts with self-efficacy.
Self-efficacy. It sounds a lot like self-esteem, but there's a distinct difference, isn't there?
A major difference. Self-esteem is about how much you like or value yourself. Self-efficacy is the core belief that your personal abilities and efforts actually affect the events in your life.
So it's about action.
Yes, it is the belief that your actions have consequences.
So a person with high self-efficacy sets goals and is self-motivated. They believe if they put in the work, things will change.
Exactly.
And if they hit a wall, they actually request support because they believe that acquiring help is a practical step toward a better outcome.
Whereas a patient with low self-efficacy is completely paralyzed. They are plagued by anxiety and depression because their internal narrative is, why bother trying? Nothing I do will change this outcome. I have no agency.
If you have a patient with low self-efficacy, you can't just walk into the room and tell them to cheer up or, like, believe in themselves. How do you clinically intervene to build that trait?
There are 4 highly actionable ways to build a patient's self-efficacy.
Okay, let's hear them.
First, they need to experience mastery. You set them up for small, achievable, tangible wins.
Like what?
If they are severely depressed and struggling with basic hygiene, the goal isn't get your life together today. The goal is, let's successfully brush your teeth this morning.
Small steps. Got it.
Second is social modeling.
Watching someone else succeed. Like, if they can do it, I can do it. I imagine this is why group therapy is such a staple in psychiatric care.
Absolutely. Seeing peers with similar struggles make progress is incredibly motivating.
Okay, what's third?
Third is social persuasion, which relies heavily on therapeutic communication. You actively persuade the patient to recognize their own strengths.
Being their cheerleader, kind of.
In a clinical, evidence-based way, yes. But the fourth method is often the most profound for nursing. It's about reframing physical sensations.
I want to dig into this, because this feels like a superpower for a nurse. How do you reframe a symptom?
Think about a patient battling severe anxiety or depression. They often feel intense physical fatigue. They wake up exhausted.
Right, depression literally hurts.
It does. Their internal narrative tells them, I am weak, I am failing, I don't even have the stamina to get out of bed, let alone get better. Their low self-efficacy uses that fatigue as proof of their incompetence.
But wait, telling a depressed patient that their fatigue is a good thing feels a bit like toxic positivity. You know, like, look on the bright side, you're tired. How is reframing different from just invalidating their pain?
Because you aren't ignoring the pain, you are changing the meaning of it.
Oh, I see.
You sit with the patient and say, you are exhausted today. Your body feels heavy. That is not because you are failing. That fatigue is present because your brain and your nervous system are working incredibly hard to heal and process trauma.
Wow.
Healing requires massive amounts of metabolic energy. Your fatigue is proof of your hard work.
You are taking a negative physical sensation and turning it into a badge of honor.
Yeah.
You're giving them agency over the symptom?
Yes, you are shifting their internal narrative from victimhood to active recovery. When clients build that self-efficacy, they return to the community with significantly better interpersonal relationships and functional living skills.
That is amazing.
But self-efficacy is just one psychological tool. We also need to evaluate a concept called hardiness.
Suzanne Kobas's concept of hardiness from the late 70s. This is defined as the ability to resist illness when under severe stress.
Right.
It's built on 3 pillars, the 3 C's, commitment, control, and challenge.
Let's define the mechanisms of those 3. Commitment means active involvement in life activities. You aren't passively watching life happen to you.
Right.
Control is the belief that you can make appropriate decisions to influence outcomes. And challenge is the cognitive ability to perceive change or adversity not as a catastrophic threat, but as a beneficial opportunity for growth.
The history of this concept is fascinating, honestly. Kobasa originally studied male corporate executives.
Yes, the classic study.
She found that executives who experienced incredibly high levels of stress but possessed high hardiness didn't get physically sick. The stress didn't break down their immune systems.
Exactly.
But the executives with high stress and low hardiness were constantly falling ill. Hardiness literally buffered the physical body against the chemical damage of stress.
It's a powerful demonstration of the mind-body connection. Hardiness allows the nervous system to perceive stressors as solvable puzzles rather than existential threats.
Which stops the freak out.
Right, which prevents the chronic dumping of cortisol and adrenaline into the bloodstream.
I have a massive bone to pick with this concept, though.
Okay, let's hear it.
Can we really walk into a community clinic, look at a patient living in deep poverty, facing systemic discrimination, maybe dealing with a chronic illness, and tell them they just need to view their medical crisis as a beneficial opportunity for growth? It feels incredibly privileged.
That is a phenomenal pushback, and it highlights the danger of applying Western psychological concepts universally. Hardiness is deeply fundamentally rooted in the cultural value of individualism. It champions personal control, individual achievement, and personal responsibility.
Which is very American.
Extremely. For cultures that prioritize the collective group, where community cohesion, family duty, or even spiritual surrender are valued over individual autonomy, the the concept of hardiness might feel completely alienating.
It might even induce guilt, like I'm not being hardy enough.
Precisely. It's the arrogance of assuming a psychological framework built on 1970s American corporate executives applies to a grandmother in a Navajo community or a recent immigrant relying on a tight-knit family network.
You cannot weaponize psychological concepts.
You really can't. This is why we also rely on broader, more adaptable concepts like resilience and resourcefulness.
Let's talk about resilience.
Resilience is simply the ability to have healthy responses to stressful circumstances and adapt to misfortune. It is the primary clinical moderator for anger, anxiety, depression, and PTSD.
Let's ground resilience in a modern clinical scenario. There was a major evidence-based practice study looking at critical care and ICU nurses following the COVID-19 pandemic.
Yes, a group that experienced sustained, unimaginable levels of occupational trauma.
The rates of burnout, depression, and PTSD in that population were just astronomical.
They were, but the key finding was that resilience was the primary protective mechanism against developing burnout.
The takeaway being that resilience isn't just a nice personality trait, it is literal occupational PPE.
Exactly. If healthcare systems systematically implemented interventions to build resilience, they could buffer their workforce against collapse.
Building the mind's armor isn't limited to secular psychology either. We must address spirituality.
Yes, which is broader than religion, right?
Much broader. Spirituality is the essence of a person's being, their beliefs about the meaning of life, and their connection to something larger than themselves.
It is a primary coping mechanism.
There is a specific clinical finding regarding spirituality and hope that absolutely blew my mind when I read the source material.
What was it?
Studies show a direct, measurable relationship between having hope and a reduction in actual physical symptoms of illness. Patients who reported higher levels of hope objectively experienced less physical suffering.
If we connect this to the bigger picture, it means spirituality isn't just a polite topic a nurse should tiptoe around.
No.
It is a clinically significant, evidence-based tool for symptom management. Accommodating a patient's spiritual needs, whether that means arranging a chaplain visit, facilitating daily prayer times, or just helping them articulate their sense of purpose, that is a legitimate medical intervention.
Okay, so we've built the individual. We have their biological hardware, their psychological software. But humans don't heal in isolation. What happens when we take this fortified individual and place them in a community?
We move to the interpersonal web, and we start with Abraham Maslow's concept of the sense of belonging.
Yeah.
Maslow identified belonging not as a luxury, but as a basic, mandatory human psychosocial need. He argued it requires two components, value and fit.
Value, meaning you feel needed and accepted by the group. You matter.
Yes. And fit, meaning your presence inherently makes sense in that environment. You mess with the culture and the expectations of the group.
So if you have both.
Clinically, a strong sense of belonging is directly associated with decreased levels of anxiety and alienation.
This leads to a trap I think a lot of well-meaning clinicians fall into. When assessing a patient's social life, there is a massive distinction between social contact and social support.
They are completely different phenomena.
Right. A nurse might chart, patient has adequate social support, they chat with their neighbor over the fence every morning, and they go to the grocery store and talk to the cashier.
But that is merely social contact. It's transactional small talk.
Exactly. Social contact does not provide the emotional sustenance required to buffer against the physiological stress of illness.
True social support requires much deeper architecture.
Like what?
Well, first, the client must possess the willingness and ability to actually ask for help. A patient could have 10 loving siblings, but if they withdraw into severe depression and refuse to answer the phone, that support system is functionally useless.
That makes sense. And the second component?
The second component of true support is where things get really complicated. The support system's response must actually align with what the patient wants and expects.
Oh, the mismatch of support. This is a huge barrier to healing.
It happens all the time. Imagine a patient who is navigating a profound depressive episode. In their mind, support looks like their best friend coming over, sitting on the couch in complete silence, and ordering a pizza.
Right. No pressure, just presence.
Exactly. But the friend thinks, no, depression requires action. I'm going to force you out of the house. We are going on a 5-mile hike to get endorphins flowing.
The friend means well. They're trying to fix the problem based on their own framework.
But because it is a mismatch, the patient does not perceive it as support. In fact, it becomes an added stressor. They feel misunderstood and exhausted by the friend's demands.
That is so common.
We paternalize support all the time. We force our idea of healing onto the patient rather than asking what they actually need.
True support also requires actionable material aid. It's not just sending a text saying, thinking of you.
Right.
It's giving someone a ride to dialysis. It's helping them navigate a complex insurance form. It's functional sustenance. And this highlights the irreplaceable role of the family in psychiatric recovery.
Healthcare professionals, no matter how highly trained, rotate out at the end of a 12-hour shift.
We go home.
We do. We can never replace the foundational strength, history, and love of a family unit. A priority nursing intervention is identifying family strengths and encouraging their involvement even during acute inpatient hospitalizations to build that long-term safety net.
Which brings us to a massive transition. We've zoomed out from the individual to their immediate family. Now we had to zoom out to the broader culture.
This is critical.
How does a patient's cultural background completely rewrite the rules of healing?
Well, for a very long time, medical education focused on a concept called cultural competence.
Which, in retrospect, sounds incredibly arrogant.
It was. The idea was that you could read a textbook chapter on, say, traditional Chinese medicine or Hispanic family dynamics, memorize a list of bullet points, and suddenly be competent to treat anyone from that demographic.
It essentially encourages stereotyping. You walk into a room assuming every single person from a specific ethnic group shares the exact same beliefs, practices, and values. It completely erases individual nuance.
Exactly. So the necessary shift in modern healthcare is moving away from competence and toward cultural humility.
Humility requires acknowledging what you don't know. It's a lifelong process of being inquisitive, self-aware, and actively dismantling the power imbalance between the expert clinician and the subordinate patient.
The golden rule of cultural assessment is never assume, always ask.
Always ask.
The most powerful question a nurse can ask during an admission is simply, how would you like to be cared for today? Or, what do you believe is causing your symptoms?
That second question is huge because cultural background completely dictates how a patient perceives the origin of their illness. We view things through a biomedical lens, cause and effect, viruses, neurotransmitters, the x-ray of the broken arm.
But many cultures hold natural or unnatural beliefs about illness.
Let's break those down.
Natural beliefs attribute sickness to environmental forces, cold, heat, wind, dampness. If you are exposed to a cold draft, that natural force disrupted your body's equilibrium and caused the pathology.
Okay, and unnatural beliefs.
Those attribute illness to outside agents, supernatural forces, angry spirits, magical intervention, or retribution for a past misdeed.
This is where clinical judgment and cultural humility are severely tested.
Oh, absolutely.
Let's role-play a clinical scenario to figure out how a nurse actually handles this. You have a patient admitted for acute schizophrenia. They are having terrifying auditory hallucinations, but they hold a deeply ingrained, unnatural belief system.
Okay, setting the scene.
They don't believe they have a neurochemical imbalance. They believe they are being tormented by an angry spirit. Because of this, they completely reject their prescribed antipsychotic medication, and they want to use traditional cultural remedies instead.
A clinician lacking humility will walk into that room and say, spirits aren't real. You have a dopamine imbalance. Take your medication or you won't get better.
Which immediately destroys all trust. You've just called their reality delusion.
Right, you've lost the patient. A culturally humble nurse approaches it entirely differently. You explore their reality without judgment.
What does that sound like?
You say, tell me more about the remedies you use at home to protect yourself from these spirits. What has worked for you in the past?
You treat their belief as valid clinical data.
Yes. You find out what they value, and then you build a bridge. You negotiate. I respect that these traditional practices bring you peace. Could we integrate this daily medication alongside your traditional remedies?
I see.
The medication might help quiet the environment so your spiritual practices can be more effective. You emphasize respect and alignment rather than correction.
To systematize this kind of assessment, the roadmap provides a framework. Giger and David Hazar's 6 cultural factors.
Yeah.
We don't have to list them all like a textbook, but a few of these are absolute traps for clinicians if they aren't aware of them, like time orientation.
Time orientation is perhaps the biggest source of friction in healthcare.
Really?
Think about it. Western medicine is obsessed with precise time. Punctuality is a moral virtue. Appointments are at 10:15 a.m. sharp. Intravenous antibiotics are scheduled for exactly 1900 and 2100.
But if a patient comes from a culture with an approximate view of time, where time is fluid, dictated by social events or the sun rather than a clock, they might show up 45 minutes late to an appointment.
Yeah.
Or they might take their psychiatric medication whenever they sit down to eat rather than at a strict hour.
And how does the healthcare system usually respond?
We label them non-compliant. We chart it. We get resentful. We assume they don't care about their health.
Non-compliant is a heavily loaded punitive label. It implies defiance. But if the root cause is a cultural time orientation, the patient isn't defining you, they're just operating on a different temporal reality.
So what's the intervention?
The intervention isn't to scold them. The intervention is to bridge the gap through education. If a medication truly requires precise chemical timing to maintain a therapeutic serum level, the nurse must explain the why behind the strict schedule in a way that respects their lifestyle.
Communication and space are two other massive factors in that framework. And it's not just language barriers, it's nonverbal. Direct eye contact is a perfect example.
Oh, yes.
In Western culture, if you look me in the eye, you are honest and respectful.
But in many cultures, maintaining direct eye contact with an authority figure, like a doctor or a nurse, is considered highly disrespectful, even aggressive. If a nurse assumes a patient looking at the floor is depressed or hiding something, they are failing to apply a cultural lens.
And regarding physical space, we have to acknowledge the permanent cultural shift caused by the COVID-19 pandemic.
Absolutely.
People have recalibrated their internal alarms regarding physical proximity. Even without mandates, many patients require significantly more physical distance during an interview to feel safe. A nurse leaning in too close to build rapport might actually be triggering a threat response.
That's a great point. Another crucial factor is social organization, particularly regarding decision-making. We talked about individualism earlier.
Yeah.
In Western hospitals, we demand individual autonomy. We expect the patient to read the form, sign the consent, and make the choice right then and there.
But if a patient comes from a collectivist culture, they might completely refuse to make a medical decision until they can consult the patriarch, the matriarch, or the entire extended family.
And again, the uneducated clinician charts, patient is indecisive or lacks understanding. No, the patient is deferring to their cultural social organization. You have to make space for the family in the decision-making process.
Okay, we are in the home stretch of this roadmap. We have built the biological individual, we've armored their mind, we've integrated them into a support system, and we've assessed them through a culturally humble lens.
We've covered a lot.
But there is one final, overarching reality we have to face. Because even if a patient has perfect genetics, incredible psychological resilience, and a nurse who provides flawless, culturally attuned care, that patient cannot heal if the environment they live in is actively trying to kill them.
We have arrived at the social determinants of health, the SDOH.
This is where we zoom out to the macro, systemic level, the conditions in the places where people live, learn, work, and play that dictate their health outcomes.
The framework breaks this into major pillars like economic stability, neighborhood environment, and education. But I want to zero in on one specific aspect of education that nurses deal with every single day.
What's that?
Health literacy. It is the silent epidemic in healthcare. Health literacy is the patient's actual ability to find, understand, and use information to make health-related decisions.
This is what terrifies me. A clinician can spend 30 minutes delivering the most eloquent, evidence-based explanation of a new psychiatric diagnosis. They can hand the patient a beautifully printed discharge packet. But if the patient has low health literacy, if they cannot comprehend the medical jargon, or if they literally cannot read the instructions on the pill bottle, the entire intervention fails the second they walk out the hospital door.
Which is why relying on nodding is dangerous. Patients will nod to save face.
Because they're embarrassed.
Exactly. Assessing literacy and utilizing the teach-back method, having the patient explain the instructions back to you in their own words, is a non-negotiable nursing responsibility.
What about the physical environment?
The neighborhood. What's fascinating here is how the social determinants bridge the gap between bedside nursing and public policy. Think about a patient battling severe depression. We can give them SSRIs, we can teach them self-efficacy, we can involve their family.
But if we discharge them back to a neighborhood plagued by gang violence, food insecurity, and housing instability,
where they don't know if they will be evicted next week,
their physiological priority will always be survival, not mental health optimization. You can't meditate your way out of a food desert.
Exactly. Treating a respiratory infection is pointless if you send the patient back to an apartment filled with black mold.
Right.
The biopsychosocial model demands that we recognize these systemic barriers. It means the role of the nurse extends beyond the bedside. Clinicians must be advocates for community resources, social work interventions, and broader public health policies.
We have covered an immense amount of ground, from the cellular level of pharmacogenetics to the macro level of systemic poverty. Let's synthesize this. For the student or the practitioner listening, what is the core takeaway?
The core takeaway is that clinical safety requires treating the whole human, not just the diagnosis. You must assess their developmental stage to understand their baseline coping skills.
You must monitor their biological response to medications with extreme vigilance.
You empower them by reframing their struggles to build self-efficacy.
You identify true social support.
And you approach their cultural worldview with absolute humility.
You ask, you don't assume. And you remember that their zip code might dictate their health outcomes more heavily than their genetic code.
I want to leave the listener with a final provocative thought. We have spent this entire time analyzing how to assess the patient's culture, their background, their biases, and their environment. But clinical mastery requires you to turn that lens inward.
That's uncomfortable.
It should be. What are the deeply ingrained illness beliefs that you bring into the clinic? Do you harbor a strict, rigid biomedical bias that silently judges a patient's spiritual beliefs as foolish or uneducated? What is your cultural orientation to time, and how quickly do you become resentful when a patient operates on a different clock?
We all have a cultural footprint.
Yes. And until you map your own footprint, until you ruthlessly identify your own biases and blind spots, you can never truly create a safe, judgment-free space for your patient's reality.
Think back to our opening mystery. Those two individuals, starting in the exact same chaotic environment. The difference in their outcomes isn't magic. It is a highly complex, often invisible web of genetics, psychological hardiness, matched social support, and cultural worldview.
And your job as a clinician isn't to judge where they ended up.
Your job is to untangle that web, understand their unique blueprint, and help them build the resilience they need to survive the storm. To you listening, thank you for joining us on this deep dive. Take this biopsychosocial framework, these clinical insights, and bring them straight to your next exam, your next clinical shift, and your everyday interactions. Stay curious, stay humble, and we will see you on the next deep dive.